Our final speaker for this session is Associate Professor Andrew Oudie, who is a honorary Australian, although he's a proud Kiwi who really enjoys his rugby union, which makes it all the nicer that he's now in Melbourne and not with us in Brisbane, because it's a tough time to be a Wallaby supporter. But Andrew did an outstanding PhD here, looking specifically at augmented renal clearance and the implications for that for drug dosing. And he's going to expand upon that a little bit further here and talk about it in the context of, does it lead to the emergence of superbugs? Thank you, Andrew.
Thanks very much, Jason, for the invitation to come and talk today. It's great to come back to Queensland to some warm weather, some blue sky and sunshine. It's pretty chilly in Melbourne this time of year. As already alluded to, I had the privilege of doing a PhD here with Jeff in the ICU, and it was a fantastic experience, and looked at this concept of augmented renal clearance. And I think that the sort of principle that really drove this concept or this avenue of research was the realisation that both of these two patients are likely to end up in ICU. And from looking at the patients, we can tell a few things about them. The fella on the right can't really run particularly fast, really piss someone off. And the gentleman here on the left is probably got significant comorbidity, potentially significant organ dysfunction, and they're both going to end up in ICU. And they potentially are both going to get exactly the same dose of antibiotics. Because a large amount, as Jeff has already alluded to, in terms of the prescribing guidelines. So first thing is to say that these two patients aren't equal, but we often treat them equally in terms of our antibiotic dosing decisions. But larger, as Jeff's already said, is that a lot of dosing guidelines don't account for changes in physiology that are going to be accounted for, that can be seen in the intensive care unit. So, you just go to the medicines.org.au website and look at the prescribing guidelines for piperacillin and tazobactam, and look at the recommendations for changing pip/taz dosing with renal dysfunction. So creatinine clearance that falls below 40 mils per minute, you will reduce the dose, and then even further. But above 40 mils per minute, there's no dosing recommendation. You just treat everybody the same. And it's quite likely that those two patients that I presented beforehand could certainly have, both of them could have a creatinine clearance greater than 40 mils per minute. But hopefully I've been able to demonstrate just with those pictures the thought of giving them the same dose of antibiotics is just completely illogical. And you've already, so I think, Jeff again has already alluded to a lot of this in his previous presentation, is that there is a significant interaction between the bug, the microbe, its resistance pattern, its virulence parameters, the individual, the man, and the underlying physiology, their chronic comorbidities, why they're in their ICU, and then the principal pharmacokinetic profile of the drug, so how it works and what we need to achieve in terms of drug concentrations to ensure efficacy. And that interaction is complex, and it needs to be individualized. But a lot of the dosing strategies so far don't really look at that. And so my particular interest was looking then at renal changes in renal function. Jeff's already presented that slide. We obviously have significant different changes in anthropometric parameters in critically ill patients. I think a lot of ICU patients end up actually arriving looking like this, rather than actually being turned into that sort of patient. But we also do a number of other things to them. So, for example, they go on to renal replacement therapy. In the centre that I'm working at the moment, we use a lot of extracorporeal membrane oxygenation, which can result in significant changes to pharmacokinetic parameters. And also there's significant changes in intrinsic or native renal function. And I think a lot of clinicians really think about the kidney a bit like a light bulb. So it's either on or it's off. And there's a maximum sort of intensity, if you like. But in reality, the kidney operates much, much more like this, like a dimmer, where there is variable degrees of kidney dysfunction, and also can be significant increases in kidney function. And that's what we're calling augmented renal clearance. The major drivers for that are largely around the inflammatory state. There's changes in major organ blood flow, which are going to occur in the critically ill. We give these patients large volumes of IV fluid for resuscitation. We start vasopressor medications, etc. Jeff's already again mentioned these ideas of low plasma protein concentrations, extracorporeal circuits. So this leads to this idea of deranged clearance, and in particular, we're going to focus on augmented renal clearance, but obviously a significant number of patients will develop acute kidney injury as well. And then this leads to reduced antibiotic exposure, and then in combination with higher MICs, which are frequently seen in the critically ill patient, you're then going to lead to treatment failure or selection of resistant organisms. And hopefully I'll just provide some data around that. So how do we define ASC? What have we chosen to describe this as? We talk about the enhanced renal elimination of circulating solute. Relatively nebulous sort of definition, I suppose, but that relates to increased clearances of nitrogenous waste products, metabolites, pharmaceuticals, anything that can obviously be cleared by the kidney. It's often easiest to think about it in terms of creatinine clearance, because that's something which I think most clinicians are relatively au fait with. And probably the best index of renal function is indeed the glomerular filtration rate. And measuring the glomerular filtration rate, however, in clinical practice is hard. Because the most robust and indeed the gold standard methods all involve the use of an exogenous filtration marker, whether that be a radioactive iodide or any of the other radionucleotide markers or inulin clearance, for example. That's difficult in the clinical environment in terms of carting a patient off to get, for example, a nuclear medicine study done. So for convenience, we often talk about a measured creatinine clearance where we collect urine, a timed creatinine clearance. We then use a plasma concentration of creatinine to then work out creatinine clearance. And certainly, I'm not going to have any slides on the particular studies, but we have done work whereby using a use of mathematical estimates of creatinine clearance or GFR just not accurate in the ICU. And that's, that's a very logical finding. If you look at the Cockcroft-Gault equation or the MDRD equation or the new CKD-EPI equation, which are used throughout the wards to estimate renal function, they were designed for use in patients that are walking around in the community for outpatient use. They're not really going to be particularly useful in the critically ill, and indeed we have shown that. So the take-home message here, we've defined it in terms of a measured creatinine clearance, and we've used a value of 130 mils per minute per 1.73 meters squared to identify at-risk populations based on some early work, and we'll have a look at that. In terms of the epidemiology of this phenomenon, this was a study which we did as part of my PhD, which involved looking at about 280 critically ill patients arriving to the ICU with a normal plasma creatinine concentration on day one. They had to stay in the ICU until the day after the next calendar day. We had 4 sites here at Brisbane, Singapore, Portugal, and Hong Kong, and we just looked at what happened to their creatinine clearances over time. This is a study looking at the percentage of, this diagram I should say, looks at the percentage of patients with ARC, and on day one it's around about 40% and it increases to 50% for the first 7 days in ICU. And then in those patients that were at most at risk was really the trauma population. Those are the inverted triangles. These are their mean creatinine clearances on day 1 through day 7. And you can see in those patients admitted with trauma that their clearances get substantially higher than what that you're going to see in a patient that's in the community, walking around in the community. And yet, as I've already alluded to, we don't give those patients any sort of, or mostly we don't give them any different drug dosing. What are the other risk factors for ARC then in the critically ill? These are some examples. We've seen it in young traumatic brain injured patients. We've just done some recent work which looked at the levels of atrial natriuretic peptide in patients with TBI. We've shown that that is increased, and we know that ANP leads to a significant increase in natriuresis and diuresis, and that may be a significant driver of ARC in this population. It's also seen in young patients with trauma. And certainly, young kidneys is definitely a risk factor in this instance, where you perhaps have a greater degree of renal reserve, which enables you to increase your clearances dramatically. Major burn injury, which is associated with significant inflammatory response, febrile neutropenia, and also, a real hallmark of all of these patients with ARC is that they have a low illness severity scores, or in this case, SOFA scores. So Here, the patients with ARC tend to have a lower degree of illness severity, and that is a problem from the point of view of trying to work out whether or not ARC and therefore underdosing of antibiotics is associated with an increase or with negative patient outcomes from the point of view of mortality, because if these patients have lower SOFA scores, they're less sick, they're less likely to die. So working that out is actually a little tricky in terms of teasing out that relationship. Already mentioned, we would have seen this numerous times. What we're interested here with in terms of augmented renal clearance, in terms of the implications for antibiotic dosing, antibiotic exposure, is really with time-dependent antibiotics and those with concentration and time-dependent features, such as the fluoroquinolones, but also more importantly the glycopeptides, and certainly the beta-lactams in terms of their being time-dependent and achieving adequate time above MIC. So this was the first bit of work which we did looking at this. This was just perhaps a quality assurance project, which was looking at trough concentrations of beta-lactam antibiotics routinely used in our ICU, and then compared that to a creatinine clearance, which was measured concurrently. We looked at the trough concentration to the MIC ratio. Obviously, a ratio of 1 means we're achieving 100% time above MIC. And we found, obviously, not unexpectedly again, that with very high creatinine clearances, you're much more likely to have a low ratio. And with some sensitivity and specificity analysis, we found that about 130 was a reasonable marker of when that was likely to occur. We've also then looked at it in other groups of patients, which is looking particularly at piperacillin concentrations over time over a single dosing interval. These are the concentration time profiles, and these are the 4 quartiles essentially of creatinine clearance, with low creatinine clearance up here, and this is the final quartile with the highest creatinine clearances. And as you can see, again, with very high creatinine clearances, you're going to have a more rapid elimination of the drug, and therefore a longer period of sub-therapeutic concentrations. To put that into some modelling, and looked at increasing MIC concentration, so this will be the most susceptible colony of organisms, leading to the least susceptible colony of organisms. And you can see that there is a relationship with both, obviously, the organism's susceptibility and creatinine clearance. So with higher MICs or more difficult to treat pathogens, then creatinine clearance or ASC is going to be more of a problem because you're going to get a significantly lower probability or chance of achieving adequate time above MIC. Same problem also is apparent for vancomycin. This is a study which simply looked again at creatinine clearance in patients with insufficient concentrations, and again, very, very high probability of not achieving an adequate vancomycin concentration if your creatinine clearance is very high. So hopefully, what we've seen there is that you've got augmented renal clearance, which is related to systemic inflammation, very common in particular at-risk groups, trauma patients, head injury patients, leads to reduced antibiotic exposure. And then does it lead to the selection of resistant organisms? And then I think there was limited data to support perhaps that theory until some of the work which has recently been done in regards to the hollow fibre model. So you would have seen some of this work presented from earlier speakers. But this was a fantastic little study which was published in May of this year by members from the CRE reduced team. And looking at the antibacterial effects of piperacillin on Pseudomonas, evaluated in a hollow fibre model using varying methods to simulate augmented renal clearance. So essentially, it was looked at the growth profiles for Pseudomonas over time, looking at 3 different populations, simulated populations. So patients that have renal impairment, so creatinine clearance of 30 mils per minute, those with normal renal function, 110 mils per minute, and then those with augmented renal clearance, or 250 mils per minute. And then this is looking at the total population of Pseudomonas over time, and looking at a variety of dosing regimens for piperacillin, so 4 grams, 8 hourly, 4 hourly, 8 hourly, 6 hourly, 4 hourly, so on. And really, first thing that, this is the control arm here, which are relatively superimposed. But the first thing really to note is that you can see only really in scenarios where there was significant renal impairment, so 30 mils per minute, and with piperacillin dosing of 4 grams 4 hourly, where you're seeing a significant impairment of regrowth, or indeed with 4 hourly dosing at 110 mils per minute. What you're actually seeing was over the first 5 hours or so in the model, there was some bacterial kill, but then there was steady regrowth of the total population of Pseudomonas in all of the other arms. And what's a real worry here is that the standard dosing, which is used in a hospital today around Australia for the use of treatment of Pseudomonas, would be 4 grams 6 hourly with a patient with normal renal function at 110 mils per minute. You can see here that by about 36 to 48 hours, there was substantial regrowth in Pseudomonas. So, that is a significant finding. It's a significant issue that even current dosing in patients with normal renal function, not augmented renal clearance, but normal renal function, is not going to be adequate to prevent regrowth of Pseudomonas. The other issue, which was really neatly illustrated, was that in those patients with normal renal function, again 110 mils per minute, you could actually see that over time in a drug-free agar plate that the MIC over time actually increased. And the reason for that was that you were actually seeing selection pressure, which allowed the selection of drug-resistant colonies. Whereas in the ARC category, in the ARC group of patients, there was essentially the MICs tended to stay the same because none of the Pseudomonas was actually being killed. So therefore, the total population remained the same. So there wasn't the same selection pressure. Whereas in this group with normal renal function, you were getting intermediate exposure, if you like, and therefore you're seeing the selection of drug-resistant subpopulations, which I think is amazing bit of work which illustrates just how important achieving adequate drug exposure is going to be for the prevention of subsequently of resistant strains. So in conclusion, ARC is likely to complicate antibiotic dosing for a number of ICU patients, particularly younger patients with traumatic brain injury, multi-trauma, burns, and we need to consider empirical dose adjustment for those patients, and particularly when you are thinking about using time-dependent agents. Higher drug exposures, I think, are going to be needed to ensure clinical success, and that's certainly what the hollow fibre model tells us. And then selection pressure does occur, even in patients, it occurs particularly in patients with normal renal function, and in those that are receiving standard doses. Thanks very much for your attention.